Hello. Good morning, everyone. We hope everyone is doing well. We would like to introduce you to Know Your Numbers webinar with our special guest speaker, Dr. Bennett Michell. Dr. Michell, how are you doing?
Good morning. Doing just fine.
Fantastic. We're very happy to have you with us today.
Thank you. Hello, everyone. Thank you for joining us on this Saturday morning. Knowing how valuable Saturday morning is, I will be respectful of your time and try to get you in and out in an efficient manner. We need to talk about some important subjects. Know your numbers. That will include subject matter of hypertension, diabetes, and other conditions that are associated with that. I will present this in a series of 3 scenarios, all of which will be demonstrative of the importance of knowing your numbers. So let's get started. All right, the first scenario, patient is a 42-year-old male with history of diabetes and hypertension who had not been seen for cure for 2 years due to lack of health insurance after the loss of his job during the coronavirus pandemic. The patient had previously been on medication, but none for the past few years. He presented with symptoms of tingling in his feet, dizziness, frequent urination throughout the day, and increased thirst. The patient stated he checked his finger stick blood glucose a week ago and was in the range of 250 to 350. These are the vital signs of that patient. He's 5 feet 11 inches tall, massive at 388 pounds with a BMI of 54 and a blood pressure of 158 over 100. All significant numbers. Labs on this individual, blood glucose was quite elevated at 365 with an A1C of 14. If you see it in red, it's abnormal. The estimated glomerular filtration rate, EGFR, was in a normal range. However, his urine microalbumin to creatinine ratio was elevated. Normal is 30, less than 30, and he was 310, so there is some renal involvement in this issue. Lipid panel, cholesterol was 191, normal total cholesterol, so he was in the normal range, but his good cholesterol, VHDL, was 33, triglyceride 302, and the LDL, the bad cholesterol, was 118. We generally talk about the good cholesterol as the one that carries the bad stuff away from the arteries, and the LDL carries the bad stuff that clogs up your arteries to the arteries. So you want a high HDL and a low LDL. All right, let's address his hypertension. He was 158 over 100. Hypertension, one of the most common reasons for an office visit, and almost 50% of the people with hypertension are not adequately controlled for various reasons, including having the medication but not actually taking it. Medications, if you don't take them, they don't work. So how do we define hypertension? First, you have to do proper measurement techniques. Word to the wise, if you're seeing your doctor, don't drink that cup of coffee, have that cigarette, rush into the office running late for your appointment, and then have your blood pressure checked. It is likely going to be higher than usual. A good idea to check your blood pressures at home and know what your general blood pressure average is. It's usually going to be higher when you're seen in the office. These are the normal blood pressures you see here. Normal systolic is less than 120 and the diastolic is less than 80. And then you get into elevated blood pressure levels with higher numbers. Different stages of hypertension. The higher the value of systolic and diastolic blood pressure determines the stage. You have stage 1, 2. It doesn't really matter so much the stage, other than the fact that as the stage is higher, you're likely to be on more than one medicine. And it's not uncommon to be on 2 to 3 medications to adequately control the blood pressure. What are the risks? Age, of course. As you get older, you're likely to have an increase in your blood pressure. However, children are now moving into the grouping of people who have high blood pressure. Children who are severely obese, 9% of them will have hypertension. Obesity, another risk factor. We are in basically an epidemic of obesity in this country. Greater than 40% of the people in this country are obese, and that includes our children. That is getting to be an issue within the children as well. Family history, 2 times more common if one or both parents have hypertension. And of course, there's a genetic factor involved. High sodium diet, don't be one of those. First thing you do when you sit at the table is reach for a salt shaker without even tasting the food. Excessive alcohol consumption. What is excessive? I don't ask my patients how many drinks they have in a day. I ask them what size and what do you drink? Because if they say they have 2 drinks a day, that may be 2 bottles of wine or whatever. Excessive is for a male greater than 2 glasses of wine in a day, for a female 1 glass. Physical inactivity, that is a significant problem as we are getting to be more sedentary in our society and our work activities. Sedentary activity works against us. One of the things I would like to highlight from the 100 is we are currently in a spring into action competition. Last spring, we had the first of this spring in action. We had 2 teams of 10 individuals who participated in walking activities and recording their steps, and accumulated weight loss over a 3-month period during the spring. In that activity, we had a total of 38 pounds lost between the 10 people. They reported steps of 4.16 million steps in a 3-month period of time. That equaled to about 2,365 miles of walking. And that would have been the equivalent of walking from Las Vegas to Boston, Massachusetts. We're currently in another phase of spring into action, and we have 2 teams, and we'll see how it goes. But physical activity is important in lowering the blood pressure. What are the complications of hypertension? Enlarged heart, big muscles in certain parts of the body is good, but not in the heart. You end up with left ventricular hypertrophy, which at some point will decrease the functional capacity of the heart. It leads to heart failure, that is congestion, fluid accumulating in the lung and in the lower extremities. Ischemic attacks, ischemic strokes, that is your classic stroke where circulation is not going to the brain. Intracerebral hemorrhage, that is an acute rupture of a blood vessel to the brain, causing really bad outcomes. Ischemic heart attack, that's your angina. Chronic kidney disease and end-stage renal disease leading to dialysis. Hypertension, most important modifiable risk factor for premature cardiovascular disease. It's underlined because it's really important for you to remember. It's the most modifiable risk factor, even more so than cigarette smoking, lipid issues, or diabetes. So hypertension is really important to control. The risk for stroke for hypertension is 2 times higher in Blacks compared to whites in the 45 to 64-year-old age group. Okay, this individual was quite heavy, 388 pounds with a BMI of 54, giving him a classification of morbid obesity. His BMI is calculated as listed here. If one is overweight, the BMI is greater than 25. His BMI was 54. Obesity in adults, BMI greater than 30, associated with 80% of type 2 diabetes. Obesity associated with 80% of type 2 diabetes. And that decreases your survival rate by 2 to 4 years. Significant. Morbid obesity, as in this individual, decreases the survival rate by 8 to 10 years and increases, with the increased BMI, you get an increase in mortality from cardiovascular disease, stroke, diabetes, chronic kidney disease, cancers, including liver, kidney, breast, prostate, and colon. One can lose 1 to 2 pounds a week simply by modifying the dietary intake. I tell my patients who are in these categories, we come to an agreement that we would like for them to lose 1 pound a week. And that can be obtained simply by decreasing carbohydrates to include bread, pasta, potato, rice, sweets, and sodas. And if one were to do that, you actually can lose 1 pound a week very easily. Childhood overweight and obesity has doubled in 25 years. It's a significant problem for children now, as they are modeling themselves after those that they see. All right. This patient had diabetes, but we also have a category of prediabetes, and that's defined as impaired glucose fasting or impaired glucose tolerance. But the bottom line is, if the A1C is between 7.5 and 6.4, one has prediabetes. Up to 70% of individuals with prediabetes will eventually develop diabetes. 30% of prediabetics will become diabetic in 3 years. They'll develop diabetes in 3 years. So if you have prediabetes, 3 years, you may likely have diabetes. And a pre-diabetic patient, each 1 pound increase in weight is associated with a 2% increased odds of progression to diabetes. One needs to increase the lifestyle activity, reduce the weight, and exercise. And that would be a minimum of 150 minutes of moderate intensity. Now, that can be simple as walking 30 minutes, 5 days a week. And that's the agreement I try to make with my patients, 30 minutes, 5 days a week. Diabetes. Now we're into the diabetes with this patient. His blood glucose was 365 with an A1C of 14. That's very high. So what is the A1C? That is the amount of sugar that is actually coated on the red blood cells and is read out as a percentage. This is how the A1C correlates with the blood sugar readings. So our patient had an A1C of 14, so he's off the chart at this point, and his average blood sugar is greater than 360 all the time. So what is required for diagnosis of diabetes? Having an A1C of 6.5 or higher. Our patient had an A1C of 14. A plasma glucose level of greater than 126, or random glucose of 200, and symptomatic. Now, this patient was symptomatic. He had polydipsia, polyphagia, and polyuria. All of that means increased thirst, increased eating, hunger, and increased urinating. All of those are a sign of symptoms of diabetes. All right, these are the recommended blood glucose levels. Before meal, 80 to 130. After a meal, less than 180. One should check the A1C at least 2 times a year if stable, meaning the A1C is well controlled. Quarterly if the treatment is changed or not in good control, and that would be an A1C less than 7. An A1C of 7 or less reduces the microvascular complications, and that would be in your eyes, kidneys, nerve endings, which leads to, in the eye, a retinopathy, diabetic retinopathy, kidney, diabetic nephropathy, and the nerve endings, diabetic peripheral neuropathy. Okay, and if you have good management, you can decrease your risk of having these consequences. All right, GFR. The patient's GFR was normal, but his microalbumin to creatinine ratio was elevated. What is a GFR? Is the estimated glomerular filtration rate, and that's how many milliliters of waste your kidney can filter in a minute. Healthy kidneys filter more than 90 milliliters per minute. This individual had a GFR of 131, but his albumin to creatinine ratio was 310 when it should be no more than 30. This is the microalbumin in this individual. Should be below 30. Okay, and then that leads to chronic kidney disease, and that is abnormality of the kidney structure or function and should be present greater than 3 months. Up to 80% of people with chronic kidney disease are not even aware that they have chronic kidney disease. The stages, we look at chronic kidney disease in stages 1 through 5. 1 is a normal glomerular filtration rate, but the albumin to creatinine ratio is elevated. And then it progresses. By the time you get to CKD stage 4, that patient is going to be referred to a kidney doctor, nephrologist, and they will start having discussions about planning for dialysis. CKD stage 5, one is going to go on dialysis, and that will mean 3 days a week sitting in a dialysis chair for 4 hours at each session. African Americans have a higher creatinine rate, so that the numbers that you may see will be higher for African Americans, but still the classifications are the same. CKD stage 2 is present in 20 to 30% of the people with diabetes. So if you have diabetes, you know what you need to know what your kidney function is like. Okay, and then the end of the CKD is stage 5, which is, and now you're headed for dialysis. Diabetes is the most common cause, and hypertension is second in that class. We look at the lipid panels, and that includes the total cholesterol, the HDL, which is a good cholesterol, triglycerides, mostly associated with your carbohydrates, and the LDL, which is your bad cholesterol. So why do we order the lipid panels? To determine your cardiovascular risk, identify with genetic lipid disorders. Pancreatitis can be an issue if a triglyceride levels is in the 700 to 1,000 range, when it should be no more than 150. Okay, manage patients with established cardiovascular disease. You already had cardiovascular disease, and now we need to manage those numbers to avoid secondary events. Also to evaluate the effectiveness of the LDL, and different statins have different potencies. All right, in this patient, this is his lipid panel. Cholesterol was in the normal range. However, his good cholesterol was low. Triglyceride was high, and the LDL, the bad cholesterol, was also high. It's a desired range, less than 100 for primary prevention and cardiovascular disease on the LDL, and less than 70 if you already have coronary artery disease or diabetes. All right, so let's wrap up on scenario 1. This is a patient with morbid obesity, hypertension, hypertensive kidney disease with CKD stage 1, diabetes, diabetic renal disease with CKD stage 1, diabetic dyslipidemia, diabetic peripheral neuropathy, was started on medication for all the diagnoses, but was lost to follow-up. And I'm uncertain as to the outcome of that patient. This patient originally had delayed his care because he had lost his job. One may surmise that the same thing may have happened again. So this patient is out there somewhere with bad numbers and needs to continue to be treated. So let's move on to scenario number 2. Patient is a 38-year-old male, was seen on a first visit in February of this year with a history of hypertension, morbid obesity, nicotine addiction, smoking a pack of cigarettes a day, dyslipidemia, and new concern for memory deficits. The patient stated both his parents have Alzheimer's, and he's concerned for his own future. Patient had not been seen by any provider for 2 years. He was on no medication and had no other symptoms. This patient comes in at 5 feet 6 inches tall and weighs 300 pounds. Again, all abnormals are in red. His BMI is 48, so he has morbid obesity, and he has obvious hypertension. So this patient was started on medication for his blood pressure, and labs were ordered, and was to return for follow-up in a week. On the return in a week, the patient did lose 3 pounds, so he was listening. His BMI dropped a little bit. His blood pressure now on medication dropped from 188 over 110 to 126 over 82. Medication is working. His lab test, cholesterol, 265, in red, abnormal. Good cholesterol, low, bad cholesterol, high, LDL. Triglycerides are elevated, and the blood glucose was 82. So his blood glucose was actually normal, but he did have an elevated A1C, which made him pre-diabetic. Okay, so he's pre-diabetic, not diabetic, but he has abnormal lipids, blood pressure that is now controlled, and his kidney function, GFR, was normal. Patient was started on a statin, atorvastatin. A CT scan was ordered to evaluate for the history of memory issues and plans for referral to neurology in the future. Followed up on the patient in April. His blood pressure was 124 over 86, still well controlled. His weight remained the same at 297. The CT scan was normal. Patient was referred to neurology for evaluation of his memory issues and was to return for follow-up in a month for a repeat lab test to see how the statin medication was working. 2 weeks later, while in a casino one evening, the patient apparently had a heart attack and expired. I did not see this patient again. The issue in this case was a 38-year-old with no care for several years and morbid obesity, hypertension, hyperlipidemia, nicotine addiction, prediabetes, who only sought care because of issues with his memory. Unfortunate case. Scenario number 3. Patient is a 52-year-old female who had not been seen for care. You're getting a general trend here, a pattern, a trend, and the trend is they've not been seen for care in all 3 of these patients. Patient, 52-year-old female who had not been seen for care since January of 21. Patient stated she had not come in for care because of COVID. She was afraid to come in and come out. Patient was seen in 2023 for physical examination and laboratory assessment with no new symptoms and on no medication. These are vital signs. Good weight for a height, BMI in an acceptable range, and a blood pressure was good. However, her lab test shows a cholesterol of 273. Good cholesterol is good. Bad cholesterol, bad. Triglycerides, bad. Blood glucose, 350. And this is a patient who was asymptomatic. So she's a chronic diabetic who's no longer aware of her symptoms. A1C was greater than 14. Kidney function, GFR, was in a normal range. Patient was started on medication, including a statin, and was referred to a dietitian because she felt she needed a little bit more education about what she should eat. She was recommended to start daily exercises. Patient returned for follow-up with labs in 2 months. She states she's taking the medication as prescribed and exercising 45 minutes, 3 times a week. It's a good initial effort. Vital signs are normal, and the patient has lost 2 pounds, so she's paying attention. Her blood glucose, now on medication, dropped from 350 to 108. Her A1C dropped from greater than 14 to 8.1, still not ideal. The A1C eventually should be below 7. Her GFR, kidney function, is good. Cholesterol was 273, was on the initial lab testing, but after on the statin medication, the cholesterol dropped to 125. The HDL is good, remains good. The bad cholesterol, the LDL, initially was 178. Now it has dropped to 54 on the statin. Triglyceride did the same thing, dropped from 177 to 58, which is very good response to statin and diabetic treatment. Patient didn't want to take any additional diabetes medicine, even though her goal is less than A1C of 7. So she was advised to continue the medication and increase her exercise to 5 days a week and return for follow-up in 2 months. So that was a good outcome. We had one that was lost to care, one that did not complete his care because he expired, and one who was responding very well to treatment. So the question to you is, what is your scenario? Do you know your numbers and have regular follow-up care? Would like for you to take control of your healthcare needs. Take your medication if they are prescribed. Medications do not work if you do not take them. Maintain follow-up care as recommended. If you have diabetes, the frequency will be dictated by how well your blood sugar is controlled. On average, one needs to be seen at least 3 to 4 times a year for good diabetic control. Participate in your care and be willing to make lifestyle modifications. That is oftentimes a significant issue. Patients are oftentimes wanting a magic pill, but they're not willing to make any changes in their lifestyles to improve their health. So I hope you know your numbers, and if you don't, when you visit your provider the next time, be more familiar with your numbers are, look at your lab test, and actively participate in the care to improve. That's what I have for you today.
Dr.
Are there any
Mitchell,
questions?
Hi, Dr. Mitchell. Thank you so much. That was super fantastic. We do have some questions. I believe Mr. Ray Lambert has a question. Step right up, Mr. Lambert. Mr. Lambert? Okay, Mr. Rayford has a question.
Oh.
Mr. Rayford, you can ask your question.
Can you hear me now?
Yes, we can
We
hear
can
you.
hear you.
Okay. Hey, Dr. Mitchell.
Hey, Daryl.
I think it would be important to tell everyone you don't have to be overweight to be diabetic, correct?
That is correct. Our third scenario was in a good weight range. She weighed 125 pounds. She was 5 feet tall. Her
Okay.
weight to height was very good, and you can still have diabetes.
Is that attributable to well,
Genetics.
okay, you answered that.
That's going to get it every time. It's going to be genetics. You got to remember your genetics, and you have to learn from your genetics. If your parents have diabetes, your chance of having diabetes is pretty good.
Well, just so everybody knows, my parents did not have diabetes.
Yes.
And I am 170 and I am pre-diabetic.
Yes.
Been pre-diabetic, and I lost 25 pounds.
And it makes a big difference too.
Well, I'm still working on it. My blood A1C was 7.4, and I'm still trying to get it below 6.
Okay.
And one of the things, Doc, I did not realize, I love milk, but that has lactose in it. Isn't that a sugar base?
It is sugar. It
Oh,
is sugar.
So I just
Absolutely.
cut that out. So I'm trying. Okay.
That can increase your glucose load. The milk can for sure.
Yeah, well, I am ice cream, and I love milk, and I'm cutting them out. So I'm now on silk.
Okay. The other thing you have to be careful with, and most people have bread with their meals. Bread is one of those high octane fuels that, I tell my patients, when it comes to eating, you should compare your eating to putting fuel in your car, because food is essentially fuel for the body. And if you read your manual in your car, it tells you whether you need low octane or high octane fuel. And if you read your body and look at your genetics, you'll know whether you need low octane or high octane. High octane is going to be your carbs, your bread, pasta, potato, rice, sweets, and sodas. So I asked them to try to decrease those, and it'll make a huge difference. I have some patients who will admit that, I drink 3 and 4 Pepsis every day.
Whoa.
Yeah. And I had one patient in particular who was morbidly obese, and we had the talk, and we wanted a 1 pound a week weight loss progression. And we said, okay, let's do this. Let's just have you eliminate those Pepsis and let's see what happens. I saw this lady back 6 weeks later, and she had lost 10 pounds simply by eliminating Pepsis, which is loaded with sugar.
Well,
Yeah. So you have to be aware of the fuel you're putting into your body and how well your body burns that fuel. Not everybody's a Corvette. Some are hybrids, and some are almost like battery operated with your metabolism. So have an understanding of your metabolism and how it burns the fuel.
now, one of the things that I've noticed, Doc, if I may ask this question, in the morning, my blood sugar runs about 125 to 135. But about 4 hours later, I'm around 119, 101, 110. Why is it early morning my blood glucose is high?
Your liver makes sugar overnight. Your liver is on guard through the night to make sure your brain is getting adequate amount of sugar, because that's the first deposit site for sugar is your brain. So the liver's job at night is to make sugar, and usually your morning blood sugar is going to be a little bit higher. And
Okay.
then once you're up and about, your muscles are using the sugar and your blood sugar starts to fall. That's why activity, physical activity is like free medicine. That's why I encourage 30 minutes of walking 5 days a week in a patient with diabetes.
Thank you. Very good. Okay.
Okay.
Great. We have another question for Mr. Ray Lambert. Mr. Lambert?
Can you hear me?
Yes,
you
we
hear
can
me?
hear you.
Oh, two things I want to ask, Doc. You talked about exercise and diet, and I've switched to a plant-based diet. Is that good? A plant-based?
Plant-based is very good. You're eliminating a lot of the issues you would have with the lipids, with your cholesterol. You will not be bringing in those animal fats, and your cholesterol panel should improve. It is a lower octane fuel than the carbs that you would have otherwise. So plant-based eating is very good.
Now, when you now, Doc, you said that that's a lower fuel dose. So should there be some kind of balance?
Oh, there is. Your body will handle it. I mean, it's just that you won't have rapid increases in your blood sugar by putting in the carbs, okay? And then when you get those rapid increases, infusions of blood sugars and other food content from the carbs, the body simply then stores that because you're not going to burn it. So if you get a lower grade fuel, you will burn it more slowly over a longer period of time. So plant-based is going to be a lower octane fuel and will less likely result in the accumulation of unburned fuel.
Interesting.
The other thing I want to ask you too, Doc, is in terms of plant-based food, what are some foods we should avoid? Because as you get older, you know, in terms of your digestive system, you can't digest like you used to at 25. So what do you recommend in terms of foods that we should stay away from?
Well, it depends on how your body, most of the feedback you're going to get is from your gut, okay? Most of the feedback you're going to get is as you get older, your bowel function seems to slow a little bit, okay? And most people are going to start having problems with essentially gas, okay? And certain types of food are higher gas producers, you know, like your cabbages, your broccoli, even though they're important for your diet, you have to measure out how your body responds to it. But most of the vegetables, there are no vegetables, I would say don't eat them. I'd say eat all of them. And don't forget your fruit, which we do not include as much as we should.
Some more.
We should have more fruit in our diet.
Okay.
Okay, we have another question from Mr. Joseph Anderson. Mr. Anderson, take it away.
Thank you. Doc, you're punching me in the gut with everything here. So I feel it, but I'm gonna try to stay in the ring. I'm just wondering if we can get a copy of your presentation so I can make sure the ranges that you have in most of those numbers, how they impact me. But a great presentation, Doc. Really
Okay,
appreciate
thank
it.
you. Yeah, we can do that.
Thank you.
Fantastic. Do we have any more questions from our viewers today? I do have two comments. Mr. Jamari Sharp said, thank you for the presentation, Dr. Mitchell. And then Stephen Gordon said, clear, thoughtful presentation, well done. Reminders to start now, not next week, because often we say we're going to start and we start next week, we start next month, we say we're going to start next year, and then we never start. So remind everybody to start your exercising and watching what you eat today. Thank you, Mr. Gordon. Okay, we have a question. I'm going to, Miss Glennie Gaines has a question. Miss Glennie, I'm going to put you live so that you can ask your question. Let's see here. Okay, Miss Gaines, you may speak.
Okay. Am I unmuted now?
You're
Yes,
unmuted.
we can hear you.
Okay. Good morning, Dr. Mitchell.
Hi, Gwenny.
I put the question in the chat, but I'm just going to read it to you as well. And I was saying, can you be over-medicated with prescription drugs prescribed by different doctors of different professions? Are these
Absolutely.
doctors actually paying attention to all the other medications you are taking?
Absolutely can. That's why it's important to have a primary care provider who is basically coordinating all of the care. When you see different consultants in your care, they're focusing on the area in which they specialize. The cardiologist is going to look basically at your cardiac meds, the nephrologist is going to look at the medications that affect your kidneys. And the endocrinologist is only going to look at, for the most part, the diabetic stuff. But if you have a lot of different issues, then you need one person who's monitoring all of that. And that's going to be your primary care provider who has to keep an eye on all of your medications. And yes, you can be on too much medication. And yes, there is a frequent issue of conflicting medications and medications that are combined and medications that conflict with each other, causing significant side effects, leading to patients not taking their medications because they don't know which one's causing their problem. So yes, it is a significant problem.
Thanks,
Okay,
Dr. Mitchell.
Thank you.
fantastic. Do we have any other questions? I have some remarks from Mr. Martin Walker. He said it was a great presentation. And Mr. Clarence Rogers said it was a great presentation. Fantastic. Do we have any other questions this morning?
I have one more last question.
Okay, go right ahead, Mr. Lambert.
Okay, what I wanted to ask you, Doc, is, you talk about taking medication, but how important is it for the patient to talk to the doctor about the side effects of the medication? Because there's some medication that you take and you can't be in direct sunlight. So my question is, we need to also understand the side effects of what we're taking. Is that true?
Absolutely. Absolutely. And every time you see a doctor, there should be a discussion about your medications and are you having any side effect from the medication? And, oftentimes you do have to make changes. And it is important that the provider actually listens to the patient. And if a patient says they're having side effects, they're probably having side effects. It just needs to be clear what those side effects are. But don't hesitate to talk to your provider if you feel you're having side effects from your medication, because what it leads to is then the patient, may not discuss it, but they'll end up not taking the medication like they're prescribed. And medications not taken don't work.
Fantastic. We have another question from Mr. Joe Jones. Mr. Jones, please ask your question.
Thank you. Good morning, Dr. Mitchell. Great presentation.
Hey, Joe.
My question is, and I may have missed this because I was doing double duty, doing some other stuff as well. Did you say anything about the importance of body mass?
The BMI, yes. The BMI is calculated based on your height and your weight. And, it will put you into different classes. It's going to be normal weight, overweight, obese, and morbidly obese. And all of those are determined by your height and your weight. And there is a proportionality. Oftentimes I have a conversation with the patient and I ask them, they're overweight. So I ask them, what do you think you should weigh? And of course, that number is far from where it should be. Now, we have a little bit of a problem in our African-American community, especially in our females. They all think that they should be a lot heavier than they should. And they always come up with this comment, oh, if I get to that weight, I'm going to be skinny. people are going to be saying, are you on crack or what? Okay. They're afraid to get their weight down into the range where it should be. So your BMI is calculated based on your height and your weight. And it puts you into one or the other of those categories. And morbid obesity is not a good category to be in.
Thank you, Doc.
Okay.
We have one more question from Mr. Russell Whitmore. Mr. Whitmore, take it away. Mr. Whitmore? Okay. Do we have any other questions today for Dr. Michell? Okay, fantastic.
Hey,
Oh, is there
Rhonda.
another question?
Hi, Rhonda. This is Russell.
Hi, Russell.
Hey,
Go ahead with
Doc
your
Mitchell.
question.
Hey,
Yes,
Russell.
Doc Mitchell. Hey, Doc Mitchell. Great information as usual. Juvenile diabetes. I have two sons. They're 13 and 15. How soon does that appear within a kid? How can we avoid them dealing with juvenile diabetes, or any kid for that matter?
Yeah, it's a significant problem. We had a talk not too long ago on the cooking class about childhood obesity, which ties in hypertension and diabetes. We're almost into mini epidemic, and our kids are getting obese, getting hypertension, and getting diabetes. Now, one thing you need to know about kids with obesity and hypertension, if one parent is obese, then they have a 2 to 3 times higher risk of being obese as well. If both parents are obese, then a child has a 15 times higher risk of being obese, and along with the obesity comes the diabetes and hypertension. If kids are in their adolescence and they are obese, and it's an adolescent, 80% of the females will continue to be obese adults. 30% of the males will go on to be obese adults. Okay. So obesity in childhood is a significant problem, and we need to pay more attention to it because it will lead to hypertension. 9% of the kids who are severely obese have hypertension. Okay. So obesity, hypertension, diabetes, a significant problem in our children now. And that's also tied into their sedentary lifestyle. Children don't play outside anymore, especially here in Las Vegas, but their activity level is tied to watching television, video games, and the internet. And their physical activity level is very low. As a result, they get obese, they get hypertension, they get diabetes.
Right. Okay. Thank you.
Okay.
Fantastic. Do we have any more questions this morning from our viewers and listeners? Okay, great. Well, you've been listening to the 100 Black Men of Las Vegas Know Your Numbers webinar with our special guest, Dr. Bennett Michell. Thank you so much, Dr. Michell. It was fantastic having you on today, and your information was right on point. So Las Vegas, thank you so much for listening to us today. We look forward to seeing you next time. Please enjoy your Saturday. Thank you. Bye-bye.
Thank you. Bye.
Thank you.